Good afternoon, everybody. And thank you, AIOS. Thank you, Dr. Shomshila, for giving me this opportunity as corticosteroid as the first line of therapy in uveitis. And according to Dr. Deborah Friedman, that no one is allowed to die or go blind without a trial of steroid. I have no financial interest. So before starting treatment of uveitis, few things we have to, we are expecting that should come in our mind. Is there any systemic association? Is there any infectious component of the uveitis? And is the patient at risk for recurrence or going to chronic inflammatory phase? And for treating the uveitis, the first line of therapy, as we all know that steroid is the first line of therapy. As we all know that we are passing through the COVID-19 phase, and in COVID-19 also to stop the cytokine storm, not antiviral, but only steroid is necessary. And we already come to know that from Showamu's paper that the pathogenesis of ocular tuberculosis, there are two aspects. One is the multiplication of the bacilli in the ocular tissue, or there is some autoimmunity. So anything happen, we have to start with steroid and treat the disease also. So corticosteroid as a first line of therapy in uveitis, the routes of administration might be local, might be systemic. In local delivery, we have topical corticosteroids, we have periocular injections, we have suprachoroidal injection not available till date, and intravitreal injection or inserts. And in systemic steroids, oral or intravenous. So these are all topical steroid available in the market, but for uveitis, we prefer prednisolone acetate. Why prednisolone acetate? Because it has greater anti-inflammatory effects. Why? The concentration of prednisolone acetate is 1%, penetration through cornea is high, suspension has higher anti-inflammatory effect. But there is another molecule which is also better than prednisolone acetate, which is difluprednate. Why difluprednate is more important, less frequent dosing than prednisolone acetate? Greater receptor binding capacity is the sole cause, but there is a but, that the elevation of IOP is much more in difluprednate than predfort. So return back to predfort or predacetate. And these are the corticosteroid we use in IV or oral preparation, and sometimes in intravitreal injections. So for the treatment with corticosteroids in uveitis, we have to hit first. One of the biggest challenges in referral practice is under-treatment. Many doctors reluctant to prescribe adequate steroid dosage because fear of side effects. And paradoxically, this leads to protracted steroid use higher than acceptable doses. Topical steroid, where to give? Any type of anterior and intermediate anterior involvement of pan-uveitis cases. What to search for? Granulomatous or iris nodule. If we have a granulomatous anterior uveitis, we should search for the cause from the day one, from the first attack. And whether it's a purely anterior or it's a presentation of anterior involvement of pan-uveitis. What to monitor? Elevation of IOP and corneal epithelial toxicity. Don't taper too quickly. Wait until the inflammation is completely controlled before tapering. We would ask the patient to come after 5 to 7 days after starting steroid, and to see that whether the AC cells comes down to half or not. Then we start tapering slowly. There should be zero tolerance to cells, flare, KPs, injection, and macular edema. These are two cases of granulomatous anterior uveitis and fibrinous anterior uveitis. If the fibrinous anterior uveitis associated with HLA-B27 positivity or associated with ankylosing spondylitis or psoriasis, or patient had a history of recurrent alternating bilateral anterior uveitis, then we start steroid with full strength. And in case of granulomatous anterior uveitis, we also start steroid, but we should search for the cause in these cases. In periocular steroid or posterior subtenon, where to give? Intermediate uveitis, in uveitic CME, vasculitis, contraindication to oral steroid, and anterior chamber reaction, which is not responding to topical steroid. What to search for? Cause of intermediate uveitis, because the nomenclature says if this is an anterior uveitis, there must be a cause. That might be tuberculosis, might be sarcoidosis, might be multiple sclerosis. cause of CME, and the repeat injection is necessary or not. What to monitor? Elevation of IOP, OCT-based follow-up. Benefits over topical steroid, higher local and sustained drug to eye with greater posterior segment penetration. And in this case also, there should be zero tolerance to vitreous cells or macular edema. This is a case of intermediate uveitis. We can see the CME in OCT and in FFA. Intravitreal steroid, triamcinolone, ozurdex, or dexamethasone. Where to give? In all cases, in cases of mostly non-infectious intermediate or posterior uveitis with CME, exceptions are there because some cases we cannot treat the patient with steroid or antibiotics in like toxoplasma. In that cases, we can use dexamethasone and clindamycin injection. In some cases of recalcitrant multifocal serpeginoid choroiditis where full strength of steroid, azathioprine, and ATT cannot control the recurrence of attack, then ozurdex has some role. What to search for? Infectious causes of uveitis, because mostly we like to give intravitreal steroids when it's a non-infectious cause. What to monitor? Elevation of IOP, vitreous hemorrhage, retinal detachment, and endophthalmitis. Benefit over local steroid and posterior subtenon, it's a direct action, hence greater efficacy. And systemic steroid, oral or intravenous. Where to give? Moderate to severe bilateral inflammation, which is beyond anterior segment. Resistant to local therapy. With systemic diseases, threatening macula or optic nerve. What to search for? Again, infectious cause of uveitis and systemic causes. What to monitor? Systemic side effect of steroids. Benefit over local steroid, posterior subtenon, and intravitreal steroid. In case of vision-threatening disease like VKH, bilateral VKH, intravenous methylprednisolone is the drug of choice at this point. There are some such sustained delivery and non-sustained delivery corticosteroids, mostly dexamethasone and triamcinolone, sustained delivery steroid, and ozurdex is a sustained delivery steroid, all for non-infectious uveitis. Some steroid is not necessary because in this case, Fuchs uveitis, we don't need steroid. Sometimes only steroid or subtenon steroid is too dangerous in case of toxoplasma retinochoroiditis. Sending patient home after topical steroid without seeing posterior segment is dangerous proposition. After giving topical steroid, patient has to come after 7 days, and this is the picture we have. This is a case of acute retinal necrosis. So posterior segment, seeing posterior segment is necessary. In most cases, steroid is our first line of treatment. In COVID time, should we continue steroid or not? If we have to continue, any guideline is there. Yes, there is an IUSG guideline in 2020. And in the guidelines for patients with no evidence of COVID-19 infection, immunomodulatory therapy should be maintained, but reassess the need for continued therapy and minimize the dose of corticosteroid whenever possible. 1 minute, please. For COVID-19 infection in infected patient and clinical symptoms of infection, high dose of corticosteroid may lead to high viral load. So try to reduce the dose. Maintenance at 20 milligram per day may not pose significant risk, and consult with COVID team. With severe acute uveitis, be it new onset or recurrent, and in whom high dose of corticosteroid like IBMP are traditionally indicated, like VKH, periocular or intravitreal corticosteroid should be considered alone or in combination with lower dose of systemic corticosteroid. So 5 take-home messages. Assess the type of uveitis first, anterior, intermediate, posterior, or pan. Rule out infective causes. Do not undertreat the patient with steroid. Use steroid judiciously with a vigilance towards side effects, and refer the patient without delay before developing chronicity.